right. Good afternoon, everyone. Thank you very much for coming today in person and for those who are joining online. This is a very special time in Chicago. Michigan Avenue is fully in bloom, and our fellows are also fully in bloom, right? Fellows are going to ask questions today. We've had a lot of fellow participation in recent grain rounds, so we're looking for that today as well. And we have a very special guest from University of Alabama at Birmingham. We learned a lot about the famous and quite accomplished Division of Nephrology there. Many more faculty than here, many more dialysis patients than here, a much larger health system. And the leader of the nephrology division is here today. That's Dr. Timmy Lee. He's a Mary Ingallis Endowed Chair in Nephrology, Professor of Medicine, Vice Chair of Research in the Department of Medicine, and Staff Physician at Birmingham Veterans Affairs Medical Center. Dr. Lee earned his undergraduate degree from Washington University in St. Louis, received his medical degree from Louisiana State University Health Science Center in Shreveport, completed his internal medicine, nephrology, clinical and research fellowships, and a Master's of Science in Public Health at the University of Alabama in Birmingham. He's internationally recognized physician scientist who focuses on an area that perhaps does not get enough research attention, and that's the area of hemodialysis vascular access biology. He looks at this important problem both from the clinical perspective, but also from a translational perspective. He has over 100 peer-reviewed publications and leads both clinical and laboratory-based research programs, and is very well known for advancing patient-centered approaches for dialysis access care. Also, he's very passionate about education, and this is all over his CV. He has a very long-standing commitment to mentoring medical students, residents, fellows, and trainees across the research continuum. And yesterday at dinner, we learned that many of the young people who spent time with him during their summers working on research projects end up in graduate school and medical school, and how rewarding this is for him. In addition, he has a very important role in attracting residents to nephrology, which is a very important pipeline development activity. He also has multiple internal and external service roles. The one I want to highlight today is the deputy editor at American Society of Nephrology journal Kidney 360. Many of his contributions have been recognized with several prestigious honors. I'll just mention a few of them. The University of Alabama, Birmingham Department of Medicine Excellence in Teaching Award for demonstrating excellence in teaching medical students and residents in nephrology. The University of Alabama at Birmingham Richard B. Dick Marchese University-wide Interdisciplinary Research Center Award. This award recognizes outstanding interdisciplinary research leadership. And finally, the American Society of Diagnostic and Interventional Nephrology Gerald Beathard Award for the recognition of teaching excellence, scholarly activity, and clinical excellence. On top of everything else that he does, we learned yesterday that Dr. Lee also drives his daughter around to her volleyball competitions. So Dr. Lee, we're delighted to have you here. Thank you very much.
Thank you, Tamara, for the very, kind introduction. And I wish my wife and mom could be here to hear that. So thank you for the wonderful hospitality. I've really enjoyed my visit and meeting all of you, and such a wonderful dinner last night. So thank you for having me. You have an outstanding, division here at Northwestern. So here are my disclosures. I don't think any of them impact this talk today. But first of all, I really want to just, give recognition to the people that have helped me in my career. I would not be here without these key people. And I want to emphasize particularly the trainees in this room and even the junior faculty. It's always important to have mentors, sponsors, and coaches throughout your career. So first I want to highlight David Warnock. He was the previous division chief. When I was an intern, he's the reason I'm in nephrology. So as a resident, we split the holidays. So, half the house staff does Christmas, half the house staff does New Year. So I was doing Christmas, and it's it's a really kind of really small group there, an intern, a resident, and a fellow. So Dr. Warnock was my intending, and he made that week so much fun. Developed, he really inspired a culture of curiosity and inquiry. And during that week, that's where I actually gained my research interest in addition to nephrology interest. We saw so many patients come in, with catheter infections because their fistulas are not working or their grafts were clotting. So after that week, I asked, Dr. Warnock, I'm really interested in research in this field. Anyone on the faculty doing research? He goes, you need to go see this guy, Michael Ahn. So he was my first research mentor, and really, really enthusiastic. If you guys don't know Michael, and very focused. So started a project as an intern, published, 2 papers as a resident and another 2 papers, as a fellow. So he really was the person that really got me into clinical research. Also, Denise Thornley Brown, I want to highlight her. She was really, really high in the field with the ASK study, but it seemed like every time I was in the renal wards, I had her. So we were in the trenches together, and this is where I really learned my clinical nephrology, so this is back in the day where we were doing biopsies on our own and quite frequently. And Dr. Thornley Brown goes, Timmy, don't ever schedule one for Friday afternoon, but I'd schedule it for Friday afternoon, always have a complication, and learned how to take care of patients in complications. So really grateful to Dr. Thornley Brown. And then when I was a fellow towards the end, looking at, job opportunities, this young, a professor from the University of Cincinnati came as a visiting professor, Prabir Roy Chaudhry, he's just recently finished his term as ASN president. So he was a pioneer in the field, doing, in translational dialysis, vascular access in pigs and mice. So I, really connected with them. And so when I was looking for a faculty position, I wanted to transition my research to learn more translational work to understand mechanisms. And that's why I went to Cincinnati. That's where I got my K award. He was my mentor. And then, finally, Anupam Agarwal was division director after David Warnock. And he goes, Timmy, we want to, bring you back home, invest in you, and let you start your own independent laboratory. So he recruited me back to UAB in 2013, and that's where I've been. So really want to, give thanks to the people that have helped me. Without them, I would not, be here today. And not just professionally, but, David Warnock, at the time I was, dating my wife. She was at Mercedes-Benz, in the Birmingham area, but transferred back to Chrysler, and, I was deciding where to go to fellowship. There was no match back then. And Dr. Warnock goes to me, you have a spot here. If your wife wants to move back and you're your fiance at the time, then tell her to do that. We'll support you. So really, they've really impacted both my professional as well as personal life. So really grateful to them. So I want to start off with a clinical case, and I'm sure you guys, see something like this, quite frequently. You have an older or more elderly, ESKD patient, have a fistula created about 6 months ago. In this particular case, you used it after 4 months after creation. But, in the past 2 months or so, you've been having some problems on dialysis. It's required 2 angioplasty interventions for a juxtanastomotic stenosis. He was referred to the vascular access center again today because he was having high arterial pressure and decreased clearance during dialysis. On physical exam, you have a very weak thrill, diminished bruit, and you perform a fistulogram and you confirm a recurrent juxtanastomotic stenosis in his fistula. So going to use this case to kind of go through some teaching points. I think they're really important. I think number 1, the ESKD life plan. Number 2, a little bit about the biology of why this lesion develops. And then, number 3, what novel therapies are we developing in this field? And number 4, how can we personalize this care going forward, not only in therapies, but in terms of the decision making. So here's the outline, 4 main topics. I think it's important to go over the landscape and the epidemiology of what, ESKD looks like in the United States currently. Then we'll talk about the biology of dialysis vascular access dysfunction, then a personalized approach to kidney care in ESKD patients requiring vascular access, and then end with a message for the future. So first of all, ESKD. So, this is US RDS data. This is recent data that was published, looking at, let's go back. looking at both prevalent and incident population. On the left here, this is the incident ESKD population. So these are new patients starting dialysis or reaching ESKD every year. This top line, as you can see here, these are patients that utilize in-center hemodialysis. So the majority of patients that reach ESKD utilize hemodialysis as their primary form of kidney replacement therapy. So much below here is peritoneal dialysis, and then transplant is very, very low. So again, as you can see, the majority of patients utilize or start with hemodialysis. There's been, a shift in terms of the numbers. I think we were talking about this last night. Fewer patients are actually starting on hemodialysis, and you'll see this trend as well here. This is the prevalent population, also from the USRDS from 2003 to 2023. Again, the large majority of prevalent dialysis patients, existing dialysis patients, utilize hemodialysis as their primary form of kidney replacement therapy. There was something that seemed to happen during COVID, decreased a little bit, and we've sort of stabilized. It's like not increasing, but not decreasing as well too. But if you look at the prevalent populations with ESKD, more transplant patients, but the peritoneal dialysis patient is still kind of steady at third there. So this is the hemodialysis procedure. So, this is what a patient goes through 3 times a week for, oftentimes 4 hours, at least in our patient population. So, you're getting your dirty blood, taken out, cleaned through the artificial kidney and back into, cleaner blood back into the body. So, I think when you consider, starting a patient in modality, I think, this is why I think the life plan is really important, because they're committing themselves 3 times a week for 4 hours. So the essential, components of the hemodialysis procedure, obviously the patient, the artificial kidney here, and this area, the vascular access. You need access to the bloodstream in order for the hemodialysis procedure to work. So it's very, very, critical. And this is why we call the access the lifeline for a lifetime. It not only has to be functional, but also sustainable as well. So there, for the fellows here, and you probably have encountered this, there's 3 types of dialysis vascular accesses here, each with its advantages and disadvantages. So the dialysis catheter, the advantage in my mind here is that you can use it the same day you place it, but many, many disadvantages, such as, frequent, thrombosis, oftentimes you don't get good blood flow and clearance, and then, the high rate of infections. So the next type of access, a little bit better than a catheter, but probably not as good as a fistula, but that's debatable. Is it arterial venous graft? So you're using plastic or at least a PTFE type of material to connect the artery and vein together. And then you have one needle here and another needle here for cannulation. So the main advantages of a graft is you can typically use it at 3 to 4 weeks after you place it, after it kind of embeds in the body and heals. But the main disadvantages is because it's a foreign body, you get device in you get frequent thrombosis and stenosis. So a lot of maintenance procedures required to keep that graft open, and a little, and also there is an infection risk, not as high as a dialysis catheter. And the final access, and for many, many years thought to be, the best access for a patient. And this is, part of what the Fistula First Initiative has talked about, is the arterial venous fistula. So this is using your own native vessels, connecting an artery to the vein. So the high pressure from the artery helps the vein, dilate and grow, where ideally it will look like this. This is a beautiful fistula where you can place 2 needles here. This is, for many years, been thought of as the preferred vascular access. But the main advantages is if you place it and if it matures and successfully used on dialysis, then theoretically it'll last a long time with very few interventions required to maintain patency. But I don't think that's true these days. But the main problem is 40 to 60% of fistulas created fail to successfully be used for dialysis. And there have been 2, large, one clinical trial called, the DAC study looking at clopidogrel, and another recently, the HFM study, trying to understand, how to improve fistulas, both mechanistically as well as therapeutically. So why is the type of access, really, really important? There's this is observational data showing that but again, observational that patients that start dialysis, with a fistula during the first year, they have better, survival rates compared to a graft and especially a catheter. So this survival, was significantly lower, not just at 1 year, but at 5 years, in the fistula and graft groups compared to the catheter group. So that's one of the main reasons the vascular access is important. So our group, for many years, this is kind of how our started and still work on it. Have been doing a lot of research in large administrative data sets such as USRDS and Medicare. And throughout this talk, I will talk to you about two of the articles we've published in the last, couple of years. So the first one I'm going to talk about, because this is a big controversy in the field, right? And I don't know if you guys see this in clinic, whether or not to put a fistula or graft in a patient, right? So for many, many years, the dogma has been from the Fistula First Initiative, let's try to put as many fistulas as we can in our hemodialysis patients, but what does the data show? So we did a study looking at, elderly patients, 65 years and older that started hemodialysis from 2010 to 2011. This is a combination of Medicare linked data to USRDS data. So we wanted to look at different access outcomes in fistulas and grafts, as you can see here. So you can see this is the fistula group. This is the graft group here. So so you can see in this particular year, majority of patients got fistulas placed in elderly patients. When you look at the outcome on unsuccessful vascular access, unsuccessful use, so this is like maturation failure, higher in the fistula compared to the graft. If you look at the number of interventions required to make the access functional for the first successful use, again, much higher rates of interventions in the fistulas compared to the grafts. And if you look at primary patency lost, a little bit higher in the grafts compared to the fistulas, and abandonment, that means, when you give up on the access, a little bit higher in the grafts. So you can see already what the trade-offs are between the fistulas and the grafts, right? The grafts, it tends to have better success rates, being used after it's placed and requiring few interventions to make it work. But again, longer term, if the fistula works, you have less interventions. So this particular slide here shows you the catheter dependence time, because again, you're waiting for these permanent accesses to work, right? That they're on a catheter for a longer time. So if you look at the AVG group, the graft group, you have no intervention. The time is the mean time. The median time is about a month. If you look at requiring an intervention for the graft, 2 months, and successfully a fistula requiring no intervention, 3 months, and it requiring intervention 4 months on the median time. So again, by nature, the fistula requires more time, catheter dependence time, but even more if it requires intervention to promote maturation. So just in summary here, if you look at, as we talked about in the other slide, in terms of trade-offs here, fistulas, right, requires, more likely to be unsuccessful or have maturation failures. Fistulas require more interventions, to make it functional. Abandonment at 1 year, more in grafts, frequency of interventions, to maintain patency, more in grafts, and catheter dependence times is more in fistulas. So these are the trade-offs, I think, that are really important when you talk to a patient and work with the surgeon in terms of what types of accesses you're thinking about for the patient. And again, we'll talk about why that's important in terms of the life plan. So we currently have an NIH multi-center study that we're looking at this exact same question. I think some of our studies prior have helped guide this randomized study. So multi-center study with, Wake Forest is the main site. We have Wisconsin. We also have UCLA as well too. So we're randomizing elderly patients, that would be eligible for a fistula based on their vessel sizes to either a fistula or graft. And our definition of older patients is 60 years and above. So this is funded by the NIA. So we just finished enrollment last year and we're doing the follow-up right now. And hopefully we'll have something, published in the next couple of years. But this study has completed recruitment. So why is this also important? I think our healthcare, people who, fund our program are really, really interested in this. And So we're also interested in this in terms of the vascular access expenditures. So if you look at the ESKD patients here, this is from the 2023 USRD report. We spend $52 billion taking care of about 700 to 800,000 patients, right? That's almost 8% of the entire Medicare budget, taking care of 7 to 800,000 ESKD patients. In comparison, this is how much we spend, or at least back in the day, on research, $45 billion. So we spend more money taking care of 800 so thousand patients than we do on the NIH budget. A big component of that is vascular access expenditures, primarily dealing with complications. So this problem is not only clinically significant, but also very financially significant in a time in our country where resources have become very, very precious. So I want to next talk about biology, because I think there is a way to it's important to understand how do we make these fistulas better. And I think the discoveries on the biological side will lead to, new therapeutics. So as I mentioned to you before, when the fistula fails, typically what you do is you send into an access center to get an angiogram or a fistulogram. And when you get that fistulogram, the most common lesion that you see occurs here. This is where the artery and vein meet, the juxtanastomotic area. You see a little bit of stenosis, a little bit of tightening and narrowing here. When you take tissue from this lesion, the most common lesion that you see is this. The blood vessel has three main layers, the outer layer being the adventitia, the middle layer, the media, the inner layer, the intima. Here, you can see there is such a big growth of the inner layer, the intima, called intimal hyperplasia, that is flow compromising. And this is the most common histologic lesion that you see in AVF failure, both in maturation failure as well as late failure. So why is this important? Again, we have 40 to 60% of these fistulas that are created that fail to successfully be used for dialysis. And there's no effective therapies, both to prevent this maturation failure, from occurring, and then to treat the ones that that fail and you intervene. So the most common tools that we have now, the only tools that we have now are to treat once the stenosis occurs. There's no treatment to prevent it. So that's either balloon angioplasty, you can put a stent graft in, or a bare metal stent at, kind of last resort. But now we have some drug-coated balloons, because when you when you perform an angioplasty procedure, you're damaging the endothelium and the smooth muscle cell layer. So this drug-coated balloon with drugs such as, paclitaxel can often help with the smooth muscle cell proliferation after the intervention. But as I mentioned to you before, there is no therapies, to prevent this from occurring. So I showed you that vessel before of what a failed fistula looks like on the vein side. This is what a normal vein, a cephalic vein looks like without kidney disease. Look at the adventitial layer there, very, narrow medial layer, and this intima layer compared to the previous one. You see the lining of the endothelial cells. So little or no intimal hyperplasia and minimal medial hypertrophy compared to the one that I showed you before. So our lab's been really interested in the mechanisms of how fistulas mature and fail. So this is kind of the working paradigm, of our different projects that we have. So, when you have a fistula that's created, the vein, which, is arterialized, so it's not used to seeing the new hemodynamics and flow that occurs. So it's it's getting arterial flow. It doesn't, like that. Also, when you perform the surgery, you're injuring the vessel and endothelial cell layer. So that's why the surgeon is really important in terms of how they care for the vessel. So you have an endothelial injury, increases, oxidative stress and inflammation. And one of the things I'm going to show you, it decreases NOS3 or eNOS activity. That's important for nitric oxide. We're also looking at the role of autophagy to impact this particular pathway. But eventually you have less nitric oxide produced by the endothelial cell layer. But nitric oxide, typically, if it's normal, function, is it diffuses in the smooth muscle cell layer and enhances cyclic GMP. And when that is impaired, you have less cyclic GMP, and you will have less outward remodeling and intimal hyperplasia, formation. So the other thing on the smooth muscle cell side layer we're interested in is that we see an increased role in PDE5A. So there is an inhibitor called sildenafil that inhibits that and can increase cyclic GMP. So this is kind of the working paradigm of our lab. And the reason it's important and our thought process is that if if you can find ways to enhance outward modeling and inhibit intimal hyperplasia, this may help with fistula survival as well as a maturation. So our lab has three main areas. I've shown you some of the human stuff in terms of the clinical trials and USRDS stuff. We have some number of animal models that I'll show you, and we also have an in vitro system that we have developed in recent years. So when I first got back to UAB, one of the attractive opportunities was to do, have my own lab to create, animal fistulas in animals. Maheshika Samaratha was a laboratory technician at Cincinnati, came with me to get her PhD at UAB. But the George O'Brien Kidney Center played a big role. I think that's one of the advantages we had UAB. They had the surgical core and helped us. They first created fistulas for us, and then they helped us teach us to do it ourselves. So this is a rat arterial venous fistula, our first model we started off with. We do this under microsurgery. So this is the femoral artery, and this is the femoral vein. You can see how the vein is nicely dilated there. This is a video of go back here. This is a video of let's see it. This is the video of our surgery once it's created. So it's not easy. It's done under a microscope. So we're able to do that ourselves now. We also do Doppler ultrasounds to try to make it as translational as possible because, in patients, we do regular 6-week ultrasounds. So this allows it's in a non-invasive way to detect flow as well as diameter size. So one of the first things that we saw we're interested in is the role of NOS3. So, one of the things that we found was that phosphorylated NOS3 at serine 1177 was completely gone in the AVF vein. So this kind of led us, to the initial hypothesis that maybe the nitric oxide pathway is impaired. So, during that model here, so as we were developing the rat model, we did a number of histology studies and we saw progressive intimal hyperplasia. So we felt that our rat model recapitulated the lesion that, we see in humans. And also, as I mentioned to you before, the cyclic GMP aspect we saw was significantly reduced in our, AVF vein at both 7 and 21 days compared to our, control, vein. So then we wanted to create a mouse model because we wanted to develop, do fistulas in transgenic mice here. So this is also with the help of the O'Brien Center. This is in a mouse carotid artery jugular vein. You can see how dilated the vein is. Also do ultrasound studies in the vein too for the reason to, non-invasively assess its remodeling process. So, this is an example what the blood flow progressively increases. And then we've also done some kidney models as well, showing that we, can induce CKD and create fistulas in these mice too. So we wanted, I'll show you one example of our story of nitric oxide. So we did some mice fistulas in 3 different mice, one with an eNOS or NOS3 knockout. This is a wild type with regular NOS3. And then we got an overexpression, a humanized insert of NOS3 from Chris Kevel from LSU Shreveport. So one of the first findings that we had is in these NOS3 overexpression mice, we had decreased intimal hyperplasia compared to these other, mouse types, particularly the NOS3 knockouts. So hemodynamics is really important in terms of fistula remodeling. So, I've collaborated for 10 years with a biomedical engineer from the University of Utah, Yang-Ting Xu, have a really, great relationships, real expert in biomechanics. So, and fluid dynamic modeling. So we were able to, develop, a protocol where we take these mice with fistulas, put in an MRI. So in a non-invasive way, we were able to get lumen geometry of these mice, as well as velocity profiling, where we can convert it to volumetric flow. We do this at UAB. We send them the data at Utah, and then they can reconstruct this into CFD models. So, we were able to first do this almost about 10 years ago. So we used our 3 different mouse lines here, NOS3 overexpression, NOS3 wild type, and NOS3 knockouts here. And some of the main findings that we had is if you look at the velocity profile, so the streamlines are more parallel in the NOS3 overexpression mice compared to these other 2 mouse cell lines. The wall shear strength stress restores at an earlier time point, compared to these other two mouse lines, suggesting favorable remodeling. And then the vorticity, which is a sign of turbulent flow, is less in the NOS3 overexpression. So that's where we thought that NOS3 promotes a very more favorable vascular remodeling and hemodynamic adaptation. So then I started collaborating with a biomedical engineer, a biomaterials person from UAB. We're at a conference where he was working on nitric oxide nanomatrix releasing therapies and stents, and met with him and talked about our research and asked him, is there a way that you can engineer this nitric oxide releasing system into a platform where we can deliver it perivascularly at the time of surgery? And they said, we'll do our very best. So we started collaborating. So he developed, nitric oxide nanomatrix releasing gel using his technology where he attaches nitric oxide or nitric oxide donors, NO8, using a self-assembled nanofiber, and then developed it into a gel releasing type of a platform. So we started doing studies where we applied this gel in rats, and the main concept is that this nitric oxide therapy will help mitigate the surgical injury, mitigate the shear stress inflammation, and perhaps also help with intimal hyperplasia and outward remodeling. So this is a real whole team of people. So he, Dr. June and Dr. Brott. Dr. June's a biomedical engineer at UAB, and Dr. Brott is a interventional cardiologist. So they have a small startup company called Endomimetics. And, that's part of their job. So that's part, but I do, the research work, and this is my team here. There was a number of people. Maheshika's graduated, but Kevin is still there. So one of the rationales for this perivascular therapy is you apply therapies on the outside of the vessel, right? So when you have an endothelial injury, right, it'll signal to the outside of the vessels here, the adventitial layer here, and what happens? It'll activate cells on this adventitial layer, the fibroblasts. These fibroblasts will migrate and proliferate and dedifferentiate into the media and then into other cells like myofibroblasts and smooth muscle cells. And these myofibroblasts and smooth muscle cells will again proliferate and migrate into the intimal area, leading to the products of intimal hyperplasia. Right. So, the concept is if we can direct therapy, at the region of vascular injury, that's where you create the fistulas, then it, not only will it have less or, off target effects, but you can maximize this, therapy, but also prevent this fibroblast activation from occurring. So hopefully, that will prevent all these bad things from happening. So, we tested this nitric oxide, therapy in rats. So this is an example of fistula created in a rat, again, femoral artery, femoral vein, and we applied this, gel on there. So again, the rationale is our preclinical work from the NOS3 work and the nitric oxide, leading to nitric oxide deficiency. And we're hopeful that it'll target outward modeling and intimal hyperplasia. So it took years to develop this nanomatrix gel and attach the nitric oxide. So one of the things that we wanted to make sure is that it would degrade and not just stay in there. So we've been able to design the gel where over 30 days it's gone. So this is fluorescently tagged gel, and you can see it's rapidly going away. So we've also had to kind of test the sustained release of the nitric oxide, and ideally want to target it for, for the maximum release to be at 30 days. So again, took a number of years to have this sustained release of the nitric oxide. So some of our main findings here is that when you look at the histology, this is the AVF created the control gel. This is the NO gel therapy, significantly less, intimal hyperplasia in the NO gel therapy. When you look at some of the other things we're interested in, such as inflammation, this is a Western blot showing that there's less NCP1 in the nitric oxide gel compared to control gel. Not so much with other kind of inflammatory mediators. We're also interested in its role in hemodynamics here, as I showed you in the mice. This is the rat. In the control and NO gel, the velocity streamlines were more parallel, so may impact the type of flow that you have with the nitric oxide gel. Also, wall shear stress was restored at an earlier time point compared to control gel, and less turbulent flow in the NO gel treated group. So again, it may impact not just intimal hyperplasia, but the way the hemodynamics remodel. So, we next went to through with the company Endomimetics to get an SBIR. So that our first phase 1 SBIR helped with the rat studies. So phase 2, which is a larger study, gearing more towards, FDA approval. So we needed a pig model. So the phase 2 SBIR helped fund our, developing our pig model. So this is a pig. You don't need a microscope to do the surgery. So this is the carotid artery jugular vein. The pig is the model that's preferred by the FDA for preclinical work because the blood vessel sizes are more similar to what we see in humans. And again, we are working on this with the FDA now. So in our pig studies, essentially the same thing that we do in our rat studies, we create the fistula in the pig, inject this gel here, and then when we sacrifice, it's a lot easier to sacrifice. We can get a whole bunch of tissue at different regions and analyze it. So these are some representative examples here. This is what kind of the NO gel looks like, and this is a video of the procedure. The fistula is created, and now we have the NO gel in there. And we, again, similar to our rodent models, we do ultrasounds. So we have an ultrasound machine. This is, Doppler ultrasound without, without not color. And you can see here, this is a really nice large fistula. This is the anastomosis here, and this is the artery. We also do Doppler flow as well to assess size and as well as blood flow. So some of our initial results, and we're gonna get this published or sending out for publication this week, is one of the things that we notice is the vein diameter increases over time by 35 days. It's a significantly increased compared to the control, gel group. And then the flow also is significantly increased. When you look at some of our histology here, also reduces, intimal hyperplasia in the NL gel treated group compared to the control gel treated group. So here, where are we going in the future? So we do a lot of human work with Roberto Vazquez-Badrón. We developed a biobank, so we collect fistula veins. So this is the CKD vein, is the vein at the time of new fistula creation. We collect that and harvest it. And we, with the 2-stage basilic vein transposition, you need to do another procedure 6 to 8 weeks later, so that you lift up the fistula, but also reanastomose it to a different area on the artery. So that's another opportunity to get a human vein, and that's our AVF vein, we called it. One of the things we're investigating is and what we've seen from our single cell work here is the role of the fibroblasts. There's something happening on the fibroblast side that seems to be triggering some maladaptive remodeling in the fistula. So this is what we're working on in our new VA grant. We also have a perfusion system where we can just very much in isolation understand what is going on in individual cells. So, we seed endothelial cells, in this tubing here. We have a pump to deliver laminar flow. And we use 2 pumps if we want to do oscillatory flow. So one of the things that we have noticed is, and this is part of our autophagy project, is autophagy is impaired, following, oscillatory flow here. We also have now developed a co-culture system. So we co-culture both the smooth muscle cells and endothelial cells together to make it more similar to what we see in humans. So these part of our new project. And again, we also do, some single cell, work from our perfusion system as well too. This is some of the work that is ongoing in our lab right now. So that is kind of the, work from our lab. But the next topic I want to talk about is how can we use some of the knowledge we have to personalize this approach in kidney care. So I think, this is kind of how I think about, I hope vascular access and therapies will go in the future. But however, I think this is in any kind of disease process in humans, right? We tend to, give the same drug, that's out there to every patient. I think the good examples of that was like ACE inhibitors in the past. But I think we know that, all patients are different, but, they may have the same diagnosis, but they tend to get the same drug treatment. So, I don't think a one size fits all approach is necessarily right, but that's the kind of what we do. When you give a drug, 25% of patients have no benefits. Some have side effects. About 20% have benefits and some side effects. And some have 30% benefit and no side effects, and then another quarter, no benefit, no side effects. So how do we get to this region, this particular, patient subset where they have benefits and no side effects? And I think this is the exciting part, in terms of kidney research and disease, in therapies going forward. So in terms of fistulas and vascular access, how do I think about this? I think in the future, right? So if you're getting a dialysis access procedure, and this is a study done by Graham McGregor a number of years ago from the University of Arizona. So when he was doing, fistula interventions, he'd scrape some endothelial cells here, and then he would sequence them and to understand the biology. So I think this is, something that we, in the future, if we can have, these transcriptomics as, kind of a point of care test in the future, I think it will help guide us in terms of both, the types of accesses we place, the types of therapies that we deliver at the time of access, and also the types of therapies we deliver at the time of intervention of these dialysis accesses. So again, Dr. Vasquez Bedron and our group were working on, developing, kind of a human AVF map. This is a recent paper that we had in Kidney International, just the start of it. So we're trying to understand, the mechanisms, on the human side, of the differences that we see in a regular, in a CKD vein, one that's, an early failed AVF vein, matured vein, and failed vein. So this is, we're trying to utilize the omics technology we have to personalize, our approach to dialysis access in the future. So again, I think this is what I envision to be in the future. And, and I think this could be in any therapeutic area in kidney disease. But for example, you have a patient that has a planned AVF or angioplasty procedure. Is there a way that we can have a point of care test to have, genomic profile, transcriptomic, proteomic, epigenomics, pharmacogenomics, but utilizing that with the patient information? And then based on that, we can determine, what the individual, type of response is, right? So it could be, therapy A, where this would be highly responsive. Therapy B, so responsive, and therapy C, no response. So based on this type of, technology that we have, we can choose the best therapy for the patient, getting a vascular access or a vascular access re-intervention. Again, I've talked a lot about therapies, but again, I think ultimately, the most important part is the patient. So prior to this access update, it was very much, fistula first, right? Let's try to put as many fistulas in patient hemodialysis patients that we can. But I think, we had a really nice conversation in work group, and we worked on this probably for 3 or 4 years. And Charmaine Locke was our leader. And we came up with, the approach, I think, going forward, that the patient and the life plan is important. So the theme of these new guidelines is the right access for the right patient at the right time for the right reason. So how do we utilize that? So, I think in order to optimize vascular access outcomes, I think, patient selection in terms of vascular access is critically important, utilizing tools such as vascular anatomy, age, life expectancy and quality of life to determine, number one, should they get a fistula, should they get a graft, or even should they stay with a catheter, right? So that is the theme that I talked about, a main premise for the new guideline themes. But, contingent to that, I think there's also the therapy part. When we think about therapies for patients in the future and we're developing those, right, there should also be a right therapy for the right patient at the right time for the right reason. So I think going forward, this is an example that we're really trying to focus more on a patient, centered approach. So again, I think we're all seeing this too, and this is a very interesting kind of results we published a couple of years back. Again, this is from USRDS here, and this is, we're looking. One of the main goals, we were very interested in understanding, what is the fistula kind of landscape looking like, the graft landscape looking like, and the catheter landscape looking like over a 5-year period. This is, where there was a lot of controversy about the Fistula First initiative and then kind of transitioning to the new KDOQI guidelines. So one of the things that we found over the course from 2015 and 2020, more catheters were being used and less fistulas being placed. Obviously, we cannot understand why, but also during the same period, mortality is not increasing in our dialysis patients. So is this a bad thing, right? If you look at these subgroups in terms of the difference in pre-nephrology care, right? Every single subgroup had this same trend as well too. So AVFs, were being placed in less frequently from 2015 to 2020, in each subgroup, even in the group with greater than 12 months. So we saw this consistently across, years. And don't understand the reason. Is it because the nephrologists now are having a more patient-centered care conversation with the patient and focusing on their life plan and their goals? We don't understand that completely, but we thought this is a very, very interesting finding. Again, across all subgroups, more CVCs were being used, irregardless of the time of pre-dialysis nephrology care, but also during this time, patient mortality is not increasing. So what is the message for the future here? I think for our field here, I learned a lot that cardiology is quite popular here. I think I think this is an opportunity. I think the last ASN, you saw so many discoveries and opportunities in IgA nephropathy, but I think we need to really emphasize doing more, clinical trials. I think that's how we get discoveries out, and that's how we can utilize both a patient-centered approach as well as a patient-centered approach for therapies. But you can see here, nephrology is I guess dead last here in terms of clinical trial compared to our other subspecialties. So I think this is one area we have an opportunity and really need to focus on. But I mean, in my area here, I mean, I think, industry has been really investing a lot in new clinical trials, particularly, on the perivascular therapy. All of them have been unsuccessful to date, but I don't think we should stop doing them. But I think that's why understanding the biology is critically important. But again, some of these more newer studies, the bioengineered graft by Humacyte, they're in clinical trials right now in the United States. There have been other devices, that are out there and being studied. The drug-coated balloon, significant impact, in terms of the first really positive study. So some centers are using that. And then we've seen some interest in endo AVF. So I think there is some innovation and therapies out there in this particular field. So again, going back to the clinical case here, I just want to leave you with some takeaway points based on the clinical case here. Hopefully I've emphasized that the vascular access is the lifeline for the hemodialysis patient, right? So that you have to have a functional and sustainable vascular access in order for the procedure to work. And that's really critical because, if it doesn't work well, there's significant morbidity for the patient, right? They dialyze with a catheter, increased risk for infection, but also, going to the vascular access center quite a bit. So the life plan is important. And what I would emphasize about the life plan, this is what I do for every patient. I think it starts with talking about the modality. Or number one, talking about, do you want to do dialysis, right? I think that's the first and most important conversation. We're just seeing a growing older and elderly population. And then that's when you talk about the modality, introduce them to PD. Would hemo be, a modality, interesting modality for them as well too. So if they decide to do hemo, that's where you discuss what their goals are. What do they want out of dialysis? This is where is it quality of life? What are their comorbidities? Are they frail? Because that's where you'll decide whether or not you put a fistula graft or keep them on a catheter. I think you need to talk about all those options, for the patient. So again, I want to focus, and this is what I talk to about with the patient. What is the right access for the right patient, the right time for the right reasons. And again, this is still, I think the science is really important. We need more robust clinical trials, and so we can develop innovative therapies. But I think there are some newer generations of vascular access devices, coming again. And finally, I think with everything else in the field, I think this is an opportunity, for vascular access to personalize not just the access selection, but just, potential therapies down the road. So really want to thank my laboratory group and my collaborators. This work cannot have been done without them and our research funding. But this is kind of my, work family here. Have a lot of fun. Really proud of my trainees. I'll talk about them. And we try to go out every quarter or so. So we go out to bowling. They like to do kind of competitive things to compete against each other in a healthy way. So we do that. But again, we have an R25 program where we bring in undergraduate, students, and we focus on student. A lot of these students don't have, opportunities for research, so it's an opportunity to help them open doors. And this is one of my, favorite grants that we have. Jennifer Pollock is the PI. So over the years, almost every one of my students have gone to either medical school or, graduate school. Hopefully they're focusing on kidney disease, clinically as well as research wise. So I'm really, really proud of them. They've been able to go to ASN. So this is one of the most rewarding parts of my job, even before becoming division chief, and one that I look forward to continuing every year. We also have the gap line, pipeline as well too. These are students that, have finished, college, not ready to go to the next step or need a little bit more enhancement of their CV. So another really, rewarding part of what we do in the lab, and seeing these, students, grow. So I also have life outside of work, try to promote, wellness and health. So my son graduated from high school, last year, but now doing an internship before going to college. But he was in the marching band, so every Friday night that football game. So we go all over the state and listen to them. So really, really, really fun to do that. And then my daughter, so she's a volleyball player, so she's she's on a national club volleyball team. I was telling, some of the, folks last night that, we travel every other weekend out of town. We've been to Chicago in January, St. Louis. We've been to Orlando and Indianapolis. So she wants to play, volleyball in college. So really, this is, I think, for those of you who have kids, most of the time, they're on their phones or in their rooms or something, but this is like, 8-hour drives where we're kind of able to talk and get to know each other. So really enjoy this part of my life, to be honest with you, and it helps my work life being happy at home. So thank you guys for the invitation. Really, appreciate it. You have a wonderful faculty here, and happy to take questions. Yes.